So, good morning and welcome everyone to Trauma Informed Care Concepts and Application. This training is brought to you by the Prevention Technology Transfer Center out of the Northeastern Caribbean, which is Region 2. My name is Diana Padilla. I'm a research project manager at the Northeast Caribbean Prevention Technology Transfer Center. We work out of the New York State Psychiatric Institute, Columbia University. I provide technical assistance and implementation support around equity inclusion and screening, brief intervention, referral treatment. And in between all that, I do like you folks. I wear some other type of hats. Kind of depends on what's going on that day and where I can be of service the most. And so there's an array of different things. And in trauma, you will, I have always found that has always been relevant to communities that have high rates of disparities and have been traditionally underserved and so on. And so part of that will come out in the discussion. So it all kind of intersects with the different topics that I tend to present there. So here's a disclaimer: the development of these training materials is supported by grant. Principal investigator is Michael Chappell, and we're funded by SAMHSA. And so we are tasked with making sure that we provide you the most current information available, and all to help support your skill set and your knowledge base. And so the Technology Transfer Centers, there's 3 different avenues that SAMHSA supports. It's the addiction field, as well as the mental health field, and also a huge focus on prevention and recovery supports. And so that's SAMHSA's way of providing you workforce or professional development support. And it's all about bringing the best practices to you, no matter what discipline you're working in. And so we are available all over the country, but here at the Northeast, we are covering New York and New Jersey, Caribbean islands, and Puerto Rico. And so those are an area, and we have a huge population, even though it seems geographically that these are small areas, our populations are quite high. So here's my traditional language matters slides. And so we always try to remind everyone of the importance of being intentional with your words and being conscious of terminology that has become dated at this point, and dated because it's not as useful as it used to be. And so the research has shown that stigma is a huge barrier to care for many communities. And so that sometimes is reflected in our language and the traditional addiction prevention, mental health jargon that we used to use. And since the DSM-5 came out in 2013, that has changed quite a bit. And so we are encouraged to use language more intentionally. And instead of being stigmatic in our language, to be more intentionally empowering, more intentionally motivated. And that's the whole idea behind People First Language. And so by doing that, we try to use affirming language to promote best practices. And so today's goals is really about, we're going to define and explore trauma. And some of this, many of you folks already know. We'll look at it from a risk factor perspective, and impacts on communities, but also on healthcare workers and your opportunities to be a support system for your clients. And so we're going to review how trauma-informed care, the guiding principles are applied in practice and settings. I'm going to have a couple of, scenarios to kind of consider things. And maybe these scenarios may be somewhat relevant to the work setting that you're in. And maybe you can add your experience or your knowledge to what we're speaking at any given point. The idea is not just to understand or be refreshed about information about trauma, because I'm not thinking anybody's starting from scratch here. I'm really thinking that you folks already have a lot of this information, but really also considering understanding how some of this information really encourages you to be familiar with some of this content, so you understand what it is that you can help with, and what it is that you may have to refer out to, like for some specialty care. So my first question to you is, why does trauma matter in behavioral health care? And if you like, you can type that in the chat box. What would be the benefits of understanding trauma in behavioral health? It can present an obstacle or barrier to treatment progress. may be a root cause of behavior. Trauma affects our responses. It better helps us understand the person in their environment, the roots that have set in. These are great. Better care of the person, foundational to, oh, they're coming in quickly. Foundational to why behaviors are happening, causes issues with the outcomes, changes the way some people think and function. Very good. I really like that. And you're going to speak to that as well. Participants have experienced trauma when presenting for services. Understanding trauma may assist in providing person-centered care. Understand people's perspective, responses to treatment, what's happening. It explains a lot of the reactions, how we can help, informs the way people feel in order to learn how to help them in the best way. We need to be informed. Thank you for that, Brianna. Behavior influences behavior. It can be important to understand one's background regarding trauma. Trauma influences behavior, provides support services, one's trauma history. You guys are great doing it. Fantastic. Behavioral responses and treatment. Trauma effects. So all of the above, you know, one of the things I just mentioned, thank you so much for all of this. One of the things I just mentioned was becoming familiar with trauma symptoms or trauma effects or reactions is really important for us, no matter what capacity you're serving. So to understand when you can make a referral, when this is the most appropriate. And then all the other things we talked about also, that about being aware and understand how it may be influencing behavior, perhaps as decision-making processes. It can further reinforce, you know, in a preventive approach, which is part of what trauma-informed care is in practice. It can also help us understand how not to re-traumatize a person. So that's something. And so we also know that it also increases risk for other mental illnesses. And so it can exacerbate someone's condition. So these are wonderful. These are really great. So let me go through some of the content here. So right up front, I just want to make some suggestions, and this is what we'll speak to throughout the content. Some of the approaches that you may want to consider in your work and in your strategies and your interactions is understanding those trauma-related reactions, like you mentioned, how to incorporate treatment interventions for trauma-related symptoms into client treatment plans. I mean, not everybody who comes in automatically gets referred to seeking safety groups, if you have those groups. So understanding how treatment interventions can be appropriate for a given person is essential. Learn how to build a safety net to prevent further trauma or re-traumatization. One of the things I always encourage, and this is no matter what topic we're talking about, is use a sociocultural perspective. Understand different aspects of a person's being, you know, their spiritual perspective, their health status, what their social world looks like, you know, what is their cultural economic background or challenges, you know, and that helps to also understand how trauma and stress can build up with a person. Understand when to make the referrals when it's appropriate. The characteristics for you as professionals, and part of the data here says, you know, have a strong self-concept. So who you bring to this work is especially important. And so I thought it'd be important to include this early on because I was talking about how personal trauma and self-care is really important. Well, in order for us to help someone else, and particularly us, especially, and considering what the population as a whole, even the global population has experienced in the last 2.5, 3 years, you know, our ability to actually regulate our thinking and emotions is very key. It's essential to our own health, but it's also essential to the person we bring when we are working with another individual who may be experiencing or may be dealing with traumatic symptoms, trauma symptoms, perhaps from a current or past situation or situations. And so being able for us to regulate our own emotions, kind of like emotional intelligence, you know, is part of the job. So awareness of our own beliefs and preferences, you know, always refer to having our own biases can help us misinterpret behavior. So again, it encourages that preventive approach. The ability to maintain relaxation, the interpersonal skills that we use. Empathy is a core of everything that you folks do. And so positive regard, those intercommunication skills are really, really important. So they also speak in how you engage a person in treatment. and how you deliver information clearly and concisely. And this is not just of how you deliver information with your clients, it's also how you assess certain situations, what you see, and how you can articulate it when you're documenting it, when you are bringing up a referral and explaining why there is a need for a referral, why you see a need for a referral. Being able to explain that very specifically is also part of what we talk about when we're speaking to trauma-informed care. So how do we understand? Let me stop the share for a moment and let me just ask you folks. Let me just get a conversation going. So how do you define trauma? What's your understanding? How do you define it? You can, anybody have an idea? I know this is not a new subject.
What was the question?
How do you define trauma? What do you understand trauma to be? Mercedes says, not the event, but how the person was affected. Who else would like to add to that?
Hi, can I hop in?
Yes, who's that?
This is Karen. Hi.
Oh, hi, Karen. Okay, go ahead.
So for me, trauma is any event that causes the person to believe that their life is at risk, so that they could die, or they could be so something that's so traumatic, and it is very much based on my perception. So somebody else, it might not be traumatic to somebody else, but it can be traumatic to me. So that covers such a range of behaviors and events. But if I believe that I could die, that has such an impact on me that anything from that is trauma.
Okay, thank you, Karen. So any situation or circumstance that may cause someone to feel threatened or perceive a threat or danger. Okay. I see some responses, experience of a high level of distress, usually something negative that poses a threat, something negative that happened in the individual's life that has negatively affected them. Response to a tragic event. Trauma is an event that the patient finds threatening, the stressful response to an experience or injury. All of the above, I feel like you're all really speaking to it directly and different aspects of it. So thank you for that. When we think about that, I thought I like that initially when Karen was saying about perception of threat, you know, that's really huge. So something that you tend to see as like what I got on this slide here. So we talk about events and circumstances. Here's the interesting thing. The words, when someone presents or when we have a scientist who's been doing this kind of work, Stephanie Covington or other folks doing this kind of work, and they speak very specifically, I think about events and circumstances. I feel they are the causing factors. So that situation, something has to happen before someone feels a threat. So the event itself could be traumatic, but it kind of depends. If we think about how traumatic, how some events have been very tragic events, and how everybody does not necessarily respond the same way. Like any given situation, you will find people that do not respond in a way where they feel threatened and they feel like there's some danger. Otherwise, everybody would have PTSD pretty constantly. So it really does speak to a circumstance or a situation that person experiences, and that person experience kind of determines whether it's traumatic to them or not. And that includes those aspects of danger, of threat, that negative effect that all of you folks talked about. And so interpretation by the person, how that person interprets that situation is really key in how you define how a person defines trauma. And it also includes the long-lasting effects. Sometimes they're acute effects, but many times it has some long-lasting adverse effects where it impacts different areas of their life, and maybe physical and other and mental health. And so when you think about the correlation with substance use, there is some statistics. This is just a few. There's so much. Up to 3/4 of people who have survived abuse or violent traumatic experiences report problematic alcohol use. We know anywhere up to 1/3 of people who survive accidents, illness-related, disaster-related traumatic events report that problem alcohol consumption. especially if they experience persistent health problems. If they are in a place where, if they resulted in chronic, a recuperation process that included chronically feeling the pain or the adverse effects from accidents. I've known folks who have been in 2 or 3 car accidents where several people were involved, and someone may have met their had died from there, and different people in that same situation had different reactions. One of the drivers did not have PTSD. She was hit head on by another driver, and there was alcohol involved. One of the other people did transition, did pass away, and everybody had different reactions. It's really very interesting on how that happens. They all experience the same situation, the same tragic situation and consequences, but they did not interpret it the same way. Men and women who have experienced sexual abuse have high overall rates of alcohol and other substance use disorders. And so one of the things, and I just kind of wanted to hit this on straight on, most of us also know about the adverse childhood experience study, the ACE studies. Folks who have, and this is an interesting correlation with, you know, when a person starts using substances very early on in age or as an adolescent or as a child, you know, they're more likely to develop substance use disorders later on. Well, the things that puts them in position with a higher vulnerability or higher likelihood, higher risk factor to develop substance use and mental health are the experiences they went through as children when they were still underdeveloped processes. A lot of different factors are mitigated, you know, the danger aspect, the negative repercussions. So kids, males who were exposed at a young age to emotional abuse, they found that out of 17,000 people they followed, I think this was over a 10-year period, the males have reported 7.5% emotional abuse, almost 30% physical abuse, 16% sexual abuse. With female participants, it was 13% had emotional abuse, 27% physical abuse, and 25% sexual abuse. All of these, when you look at the hierarchy in this pyramid, what you find is that it affected all these other areas of development as they go into adulthood, and a lot of times affected mortality. And so disrupting what would have been an ideal, you know, development process, those are impacted by these negative experiences, the social, emotional, and cognitive impairment, and the person continues to develop with these impairments, you know, physical issues, disease, vulnerability to different health issues, and the mortality. All of that kind of speaks to the younger you are when a person experiences these different adverse situations, and the impact, it puts you in a position into adulthood, if you reach adulthood, to be more vulnerable to substance use and mental health or co-occurring disorders. And so, and one of the things I want to mention, and I'm going to make the case right here, this is mental health, substance use, and suicide ideation. This was very specific to that first year when the pandemic hit. Yeah. And which was interesting that they collected this data. But by June of 2020, about 40% of adults reported struggling with mental health and substance use. Now we're just kind of coming out of that. And what we have seen is that these numbers are actually a lot higher. And what we've noticed is that not everyone understands how to process what we just finished surviving in healthy ways. So when we see some of our patients and clients with substance use and mental health, you know, where they may have had this behavior before the pandemic, or it started during the pandemic, or it got exacerbated, progressed during the pandemic. This is part of what we see, the intersections between substance use, suicide ideation, mental health. A lot of folks right now may be presenting with issues of trauma, and we don't necessarily know, but that doesn't mean that they have actually processed it. And this is why we're going to talk about some of the things we might see. And so some of the theories that do exist of trauma linking to substance use, there are different, there are some scientists that think people with like extreme trauma are the diagnosis post-traumatic stress disorder. They use substances, PTSD use substances to cope with or counteract their symptoms. Many people with mental health issues will may take medication, or instead of taking medication, will use substances to mitigate the symptoms they're experiencing. So that's not always with the diagnosis. That's a lot of times, this is with the diagnosis, and a lot of times, many of us would likely have had clients who have tried to address their symptoms with medication, whether it's unprescribed medication or smoking marijuana or having extra drinks or so on. The high risk hypothesis has to do with people who use substances tend to have high rates of trauma as a result of their substance use or consumption levels. And then there's a susceptibility hypothesis where people who use substances are more likely to develop PTSD after exposure to trauma than those who do not use substances. And when we think about it in a relational perspective, think about there are times where folks, because of their substance use, they might find themselves in certain areas, certain situations they would normally be at, and that puts them at high risk for occurrences, situations, for events to happen, and that, so there's a relation between person using substances and the increased potential for trauma. In terms of COVID, and I'm going to ask you about this too. So when we had to shelter in place, and we think back of that, fear of losing connection with individuals was pretty high amongst almost everybody. Nobody knew what that was going to look like. And it was a scary thing that you could not go out to interact with people. It was like a weird sci-fi suspense movie to pass through New York City and not see other cars. I had an emergency that I had to go from the Bronx to Brooklyn at the time, and not to see other cars, not to see other bodies in the streets. And it was really, it was like Tombstone, like the movie, where it was like really desolate. And so being in that environment, not connecting in person with other people, and that as a new experience, even though CDC was asking us to shelter in place, many people interpreted that as a shutdown or a lockdown. And so that also affects how people interpret their environment or any given situation. So the isolation was not exactly, was something that a lot of people had to adjust to. People are making there are sacrifices that people were making on a day-to-day level, which were equally traumatic compared to the virus itself. What does that speak to? What are those day-to-day sacrifices that some people had to make despite the guidelines, despite that the virus was, particularly when it was very new? What do you think this is speaking to? Yes, Amanda, going to work, being essential employees. So essential employees, and essential employees had a really broad definition. We automatically think of the medical practitioners, the nurses and all those folks involved. Who else had to go to work? Yes, people who did go to work had to restrict seeing their loved ones. Grocery store workers have rights. Pharmacy technicians. That's right, there was socializing in general. Also, and who has medical staff? We're talking about truck drivers, we're talking about messengers, we're talking about folks who, if they don't show to work, the restaurant folks who were working behind the scenes, people who had to get and commute on public transportation, as limited as it was, people had to commute with other people. All of these folks, there was a wide scope of who the essential workers were. And a lot of these folks, the communities needed them. And for some of them, if they didn't show, they just did not get paid. So huge sacrifices. And then not being able to come back to your family. For a lot of folks had the opportunity to stay somewhere safe away from the family because they had to be in person at their jobs. And how many of you folks were tasked with coming into work? You had to come into work. I mean, I don't think The field of prevention and treatment did not have a protocol in place as to how do we hit the ground running and still take care of our patients and our clients. Many of us had to go in person. And so the trepidation of going in person, knowing that you might pick up something and bring it back to your family, let alone get yourself infected too. And this is talking at a time when we didn't know what we were dealing with. Huge, huge stressor. So yeah, substance use counselors, people in recovery, so sponsors, left the country in state of, people left the country in state of anxiety and depression. And it's a funny thing because we left the country and other countries were going through a lot of the same things. The atmosphere was very similar. Had to go to work and clean every hour, but because we were low staff. People were coming for other folks. Pharmacy, I was a pharmacy technician at the time, and my roommate worked in a hospital. We were so scared that we would get COVID and pass it on to the other side. So this trepidation that we are feeling right now, thank you for sharing that. And thank you all for everything that you've done and continue to do, and for bringing yourselves to doing the work to help others. Huge, amazing hearts, and very courageous folks. And yet that trepidation that you have to deal with, that can be very traumatic. Well, this is for you folks. This is for the different people and the family members who have had experience with other members who had to go into work. So loss of preventive measures at work and going home to family to use the same preventive measures not to expose family members. Yes, and how much stress was it for everyone in the family to understand the same guidelines? That we were all clear on what we were supposed to do, and we were actually doing it. Or maybe we weren't actually, maybe one person was doing it more specifically or strictly than another person in the family. Huge stressor, huge stressor, and then the reality was the fear of losing loved ones, and many of us lost people, lost clients, lost family members, lost friends. And so that trepidation, that in itself, going through that experience, and this is why I talk about personal trauma and at first, and self-care, is because as we speak on this, don't want to minimize what we've been through. I also want to use it as an opportunity for as we go forward. So there's such a thing as reframing traumatic growth, and which is what you folks also have the opportunity to do, so you can better assist your different clients and patients as having gone through experiences yourself and actually learning and how you survive them are ways, actually gives you a lot of skill sets and a lot of strategies that you can share with your clients so they can be more resilient in how they deal with their situations. There will be some folks that will need specialty care, but there are a lot of folks that, a lot of opportunity here and experiences that you have that can influence the preventive aspect of how you engage folks in treatment. And so one of the things I also wanted to mention is that the atmosphere at the time also created a lot of racialization. The atmosphere was very adverse. We had killings going on. We had adverse effects. We know for a long time about systems, inequitable systems that we're tasked with working in. And so persons that we weren't always familiar with, but persons actually have certain symptoms that seem to reflect like PTSD, but they had very specific causes. So race-based traumatic stress, or is synonymous with racial trauma, refers to the mental emotional injury caused by encounters of racial bias, ethnic discrimination, racism, and hate crime. Can't talk about trauma-informed care and different kinds of trauma without specifically addressing this as well. It is intentionally, you can see in the title, it is not in the DSM-5 right now. And the next version is supposed to carry it. And so it has happened so much that it's hard to deny at this point. And so there's a lot of studies, and we have some resources there. There's a lot of studies that speak to how many people deal with traumatic stress on a daily basis, depending on where they're at, what they do. Being a person of color, particularly the Black communities, Black and Brown communities do have their own extra vulnerabilities to being to encounters of bias and discrimination, racism, and hate crimes. We also talk about how Black and Brown lives have been disproportionately affected by COVID-19, not just police violence. We talk about how these communities are more vulnerable to disease, psychological stresses, unhealthy behavior due to unequal distribution of resources. I am also going to add in there Indigenous peoples, as well as Asian Americans. And then I'll really speak to also about how many different folks have had their own experiences. In the Latinx community, about almost 40% in one study had talked about how they were verbally attacked for speaking Spanish, you know, how they were told to go back to their countries and the racial slurs. And when you have communities who are living in areas where this is more commonly done and stuff, this is what they have to deal with on a regular basis. And when a Black family has to, you know, speak about how to interact with public officials, with law enforcement, you know, how they have to behave in order to survive situations. Huge traumatic stress. When we think about Asian Americans who are will only access resources, who are also, the providers are also Asian American because of the discriminatory experiences that they have gone through. And so when we think about all that, we think about how psychologically the stressors, you know, really can evolve into dealing with trauma on a common basis. And so that can correlate with unhealthy behavior. A lot of times too, a lot of these communities tend to not necessarily have quality care or appropriate resources that are accessible for them. And so that can exacerbate situations for them. When we think about historical trauma and how that can trigger that, closely related to intergenerational trauma, or sometimes used, you know, interchangeably. So it can, many can may develop in a community or generation, or collectively there are experiences of trauma such as pandemic, economic depression, oppression, war, genocide, you name it. And so what we know is that it can be, you know, when we have histories of massacres and history of forced violent removals from tribal lands, for instance, for Indigenous people, you know, so you see a higher increase of symptoms among these groups or group members of not just substance use, but, you know, diabetes, depression, you know, so stress, trauma, when we think about trauma, some of the things that are presenting can be related to some of this. Now, I wanted to talk about some of the more DSM-5 recognized, because this is the version we have right now. I know they're working on evolving this and updating the DSM. And so some of the stress-related disorders that might be helpful for us to understand that we might be seeing something with, kind of depends on who you're working with. So acute stress disorder. So although it's similar to what post-traumatic stress disorder is, the diagnosis can be given within the first month after traumatic event. And so a person experiences symptoms of disassociation, like numbing or reduced awareness, or some kind of or amnesia. And so within the first 30 days after an occurrence, after a situation has had happened. So the criteria for that has a greater emphasis more on the dissociative symptoms. And this is not necessarily uncommon. A great many of us, you know, do have experiences where we may be in shock, where it may feel surreal. It may take a few days or a couple of weeks to kind of process certain situations. But when it gets to the point where these symptoms are dissociative, within the first 30 days, we may actually have ASD, you know, so our clients, in terms of our clients, it might help to have a formal evaluation done by an appropriate clinician. So the presence of 9 or more of the following symptoms from any of the 5 categories: intrusion, negative moods, avoidance, arousal, beginning or worsening after the traumatic events. That's important. So it's typically something that is experienced from one event, and someone has these symptoms like within the first 30 days. And it can be just part of them just processing a situation. So it can have some maybe memories are detailed, perhaps there's some overreactions that you may see, but then after 30 days, it kind of tends to go away. And then we are more familiar with the post-traumatic stress disorder. So these symptoms usually begin early. But early meaning within 3 months of the traumatic incident. It does not necessarily happen within the first 30 days. And so, and not everyone with PTSD has been through a pretty dangerous or traumatic situation. Sometimes some experience has a pretty sudden or unexpected, maybe an unexpected death. I think a lot of us have some experience with that, but some of our clients may have, because they have resources, they may have interpreted it in a way where it's giving them adverse effects for a long period of time. So some people who recover from trauma do it within 6 months. So people who have symptoms much longer than that may have post-traumatic stress disorder. So in order to be diagnosed with PTSD, an adult has to have the following for at least 1 month. One reoccurring or re-experiencing symptom. So like when memories or concerns about trauma interrupt like their emotional well-being. Maybe one avoidance symptoms, like staying away from, we talk about people, places, and things when it comes to substance use, but that's not dissimilar for folks who may stray away from certain movies because of their experience, they stay away from certain locations that may remind them of a traumatic experience they had, within the last year. So avoidance symptoms can also be where a person may be in the middle of a conversation, but does not necessarily connect the certain details of the conversation with what it might connect to something from the past, from that past traumatic incident. And so mentally, they are not connecting the dots. They're avoiding it. They're not necessarily recognizing the details of that situation because it has too much to do and interrelates and reminds them too much of the traumatic incident. So folks might avoid certain things even mentally. They're usually at least 2 arousal and reactivity symptoms. So sometimes when someone they can have one or another. You can either have a flat effect, or you can have a very bigger overreaction to certain things that maybe the average person may not have. And so in order to be diagnosed, this has to happen. Also impacts, your ability to work, your daily functioning, your interactions with other people. And so PTSD has its own criteria. And so, but it is really much more extreme than what we see in the acute disorder, and the ASD, acute stress disorder diagnosis. So this is more the extreme, and many people, it was mentioned in the chat box about people who have been through partner violence. They certainly have experienced this. People who have been through, who have been in the military and have been in combat theater, certainly can have that. But there's some other folks too. It depends on the individual and how they have interpreted the situation. And maybe folks who are in situations or in environments where they're highly activated, they're always on a hyper vigilant state because they have to watch themselves. Someone who may have to live in that type of environment more commonly may be at that active state. And so folks, and that might build their vulnerability to PTSD after having a traumatic situation happen to them. The one that I think we see the most of and we don't always recognize, particularly we work in treatment and in terms of, and then for many of us who work in prevention and recovery, we are seeing some of this. And so complex trauma has to do with individuals who may have had repetitive, prolonged, or cumulative experiences, which were not just negative, but pretty impactful. It could have been just mental, could have been mental and physical. Tends to happen in earlier ages. And so when you think about the ACE study, when people who have experienced at an early age these adverse experiences, they've witnessed violence in their family or their immediate environment, or they have been consistently abused, or they have been maybe malnourished over a long period of time. a lot of these intersecting issues, they have maybe had sexual abuse. So all of these can be part of complex trauma. So as a person is growing up and they haven't fully developed, some of these situations, one of the wonderful things that the human body, the mind has the opportunity to do is to adjust. The resiliency that we speak to is very specific, but when I'm thinking is, there are times where as children, people go through situations that they have not perhaps had the capacity to process in a healthy manner. What happens? The individual will adjust, will resolve it by not necessarily addressing it. In a complex trauma, think about if somebody's developing child, adolescent, young adult, adulthood. And so we have disappointments in life. Sometimes we have traumatic situations in life, and we don't necessarily resolve in a healthy manner. We kind of put it away somewhere. Life keeps going, we keep going. And so then over time, what happens in life? Sometimes some situations stay unresolved, and we've had disappointments, we've had heartaches, we've had maybe experiences that may have been tragic of all different kinds, and those tend to accumulate. And so complex trauma is really founded on the accumulation of unresolved issues. So often this occurs at developmentally vulnerable times. So think about what happens, and not just like from the ACE study, we can easily see that, where we think about a young age, a person has learned to trust, their guardian or their parents or that adult person who's taking care of them. And if that person is the one that's causing them, causing physical abuse, sexual abuse, or other traumatic experiences are happening in their environment as they're growing up, the maltreatment, the exploitation, neglect, abandonment, all of that at a young age, all of that can be foundational to other disappointing life situations. And that cumulative process can really lead to complex trauma. Many of us who do work in treatment may see some of this, but many of us in treatment and prevention, the things we are supposed to be dealing with when it comes to any given client or patient is what they present with at that moment. And so for us to understand some of this, we need to be able to be familiar with some of the symptoms so we can either refer out or at least make sure that our interactions with them are influenced from a preventive approach where we don't want to re-traumatize folks. But as we go forward, this is a lot of some of the things that we see. It's rarely did I see when I was working with my clients, rarely did I see an immediate issue that was just an immediate issue. Getting a referral to a social service resource is one thing. But when you have clients who come in who you have a report, you start to work with them on the different issues on their treatment plan, and then things start to come up and the behavior starts to change, and they start to have maybe somatic symptoms or some stress in their lives. They start to share with you about some of these situations. They start to understand that they're usually underlying currents going on. They're underlying issues that are going on that either you can address or you refer to a specialist to do, and depending if they seem to have symptoms of a particular diagnosis and your capacity. And so some of the reactions that we want to consider here are, so initial emotional reactions could be numbness and detachment. Some folks will have extreme anxiety or be fearful at the thing that maybe some of us would think, what's going on with them, because it doesn't seem like there's any danger. But for that individual, they may have had a moment where it kind of triggered a feeling that was associated with a past experience. Sometimes we downplay it. Sometimes we think it's funny, but sometimes we don't. Sometimes we actually do take a moment to think, where was that coming from? Always think about, that's happening for a reason. What might be making that happen? What is the motivation? And so that is healthy for us to think in that, for us as providers to think in that way. And so the individual may have extra guilt or acceleration, survivor guilt. How come I'm here? And why did my sister have to pass? Why wasn't it me? That type of thinking. And so you see a list of different things here: anger, sadness, helplessness, feeling unreal, disorientated, denial, restriction of feelings. And then you have delayed responses, and it might come to them later. So they might have episodes of depression. They might have episodes of anxiety. Grief reactions may not come immediately, might come later on. Maybe there is emotional detachment. And so these are a variety of different types of reactions folks might have. There is a source there that I put in for the trauma-informed care and behavioral health services. It's a lot more specific, and it's actually a little longer. I just put in some. I posted some here. Any comments, any questions, anything that comes to mind for anyone right now? Let's see. Could a death of a parent at age 7 cause this? Yeah, it could be an underlying cause. And and when you think about how other disappointments in life build upon that, it's potentially possible. I've had clients who, when they first came into treatment, and I have one client, and I remember when she first came into treatment, she had partner abuse issues. And so, and she seemed motivated to work on recovery. She didn't want to use substances anymore, but one of the things she did do was she went into treatment to address those issues of partner abuse. They use psychoanalysis, and her therapist used psychoanalysis as the approach to work with her. And over time, what they found, it wasn't the partner abuse that was actually having, that she was having issues with at the present time in her life. At that time, they found that it was that her, she called it, her therapist called it her fall from grace, was when she learned from her therapist after a session that there was a point where she had a situation and her mother blamed her for it. She actually, she was sexually assaulted without penetration, but sexually assaulted, and she was 12. And then as an adult, and in the sessions, a lot of situation, a lot of the behavior, and a lot of thinking that she was experiencing or seemed to be reflecting, it was all correlated with that and wasn't even the partner abuse. And so, so when I think about complex trauma, there are a lot of underlying causes that sometimes will be the direct, what really started the mind, maybe in an unconscious way, to help that individual feel or set themselves up even for situations later on in life. And so here I do want to ask someone, if you don't mind, I've been speaking a lot. I'd like to have someone read a case study, and then I would like to get your take on it. And what do you think of some of the reactions that you think you see? So, do I have a volunteer?
I'll read.
Okay, let me sure. Here's the case.
Okay, sorry, let me just move my pictures here. Okay, Kimmy is a 35-year-old Native American woman who was group raped at the age of 16 on her walk home from a suburban high school. She recounts how her whole life changed on that day. I never felt safe being alone after the rape. I used to enjoy walking everywhere. Afterward, I couldn't tolerate the fear that would arise when I walked in the neighborhood. It didn't matter whether I was alone or with friends. Every sound that I heard would throw me into a state of fear. I felt like the same thing was going to happen again. It's gotten better with time, but I often feel as if I'm sitting on a tree limb waiting for it to break. I have a hard time relaxing. I can easily get startled if a leaf blows across my path or if my children scream while playing in the yard. The best way I can describe how I experience life is by comparing it to watching a scary, suspenseful movie, anxiously waiting for something to happen, palms sweating, heart pounding on the edge of your chair.
Thank you so much for reading for us. So here I'm going to ask you folks, so obviously she had the traumatic experience and it is affecting her. What are the reactions that you can identify or that you would think of as that you might want to explore or document and think about maybe bringing up how to address it with her or make a referral? What are the reactions specifically that you see here that may be trauma-based?
I'd say sensitivity to sounds or like movement. So when she said the leaves pass or the children are screaming, it triggers her.
There you go. That's one. Thank you. Yes. And what else do we see?
She had a hard time relaxing, could never fully feel relaxed or safe.
Exactly. Thank you. And what's interesting is she has a hard time relaxing. She's not in the situation anymore yet. This is how she's feeling presently. That's a really good sign of saying, okay, this is correlated with, this has to be connected to something the person Kimmy must have experienced. What else do you see? Thanks for that.
I guess without knowing, she's always stuck on a fight or flight type of wavelength.
Yes. Yes. So where do you get that from? What makes you say the fight or flight?
Because she can't relax. She's always she's always ready for any and everything, because like the leaves, or like she mentioned, sitting out on the branch waiting for it to break. And that right there just signifies that. I think it embodies that meaning.
Very good. Thank you. Yes. What else?
Someone else had mentioned it in the chat. The last portion where she talks about her life is like a scary movie, that it's just constantly waiting for something to happen, heart pounding. She has very anxious traits, even though the situation's not happening anymore, that it just continues in her day.
That's right. That high level anxiety, high state of arousal that she's at. And so some folks might just refer to that being in a high, in an activated state, you know, and that means you stay there mentally, but you also stay there physically, and you stay kind of ready for something to happen, just like the folks in the chat box were speaking to, and you just did just now. And so that's a tough way to exist. I'm not even going to say the word that. It's very tough, but the people survive on this high level of anxiety. But they don't necessarily survive in the healthiest ways. And so what else do you see? Is there anything else that kind of stringing along that's kind of speaking to you that hasn't been mentioned?
I'm not sure how to raise my hand, but okay. Yeah, it's survival. It's like she said, the flight or flight, but it's subconscious. It's in survival mode. She's in survival. You know, that fear, and being presently in that same fear as it was when it happened.
Yeah.
So.
And thank you for mentioning that as well, because and here's the thing about this, the situation that she's sharing with us. She's 35 years old, yet this happened when she was 16. And so it still has a real impact, a real, a very impactful influence in her, and how she feels and how she goes through her days, and she lives at this high level state. Let me look at some of the things in the chat box. Yeah, certainly walking on eggshells, so not feeling safe, startled by movement, and that fear, the anxiety that says something's going to happen, waiting for it to happen, being on that high state. Physical symptoms of anxiety and how it can impact her health, feel detached, watching her own life like a movie. Huge. So this seems to speak to very obvious extreme symptoms. They're not always as obvious or this many, but it's something like this, when it really speaks to how much are we listening to what our clients say. Do our patients have the opportunity to actually share in detail, and they're building on the rapport that you've already established with them? Are they able to share with you in detail some of these challenges that they're going through? When you start to hear some of these details, you can't help but start to think, all right, what's really going on here? She didn't have a PTSD. Notice there was nothing that came up in her intake or in her documentation that states that she has these issues, that she currently has it. So symptoms don't always show up in the beginning. And I always refer to the protocols in place that we have, most people, to understand whether or not they can be admitted into a program, whether we talk about prevention or recovery supports, mental health or addiction. No matter what program they come into, there is an array of processes and paperwork that they have to go through. Are they appropriate for the program? Do they have mental health issues? Do they have substance use issues? Are there any other physical health issues that are going on? When we think about all of these things, well, Kimmy may not have presented, if she had come into the program and then we start to see this, she may not have presented in the data on the mental health evaluation early on, may not have captured any of this. Maybe none of this was going on. Maybe she didn't share it at that time. Maybe, and then the thing is, sometimes this will happen after the fact. like we know it does for PTSD. And when it does, are we able to kind of take up the red flags and follow through and explore this in a preventive manner that won't re-traumatize the individual? And so, yes, the constant elevated levels of adrenaline, it hasn't happened yet, but it's like a ticking time bomb. Just, could you imagine you having to live like that always? It's not, for some of us, for some of our community members that we provide services to, this may have been how it felt when they were dealing with the last almost 3 years. So thank you for the reading and thank you for your comments. So let me go on to here, and just to speak to a little bit about the neurology behind the fight, flight, and freeze. You know, it's always important to understand, for many of us who are working with people who have substance use disorders or substance use and other disorders, you know, understanding very simply, you don't have to be a neuroscientist, but just understand very simply the areas of the brain that are affected. And so we know that the front part of the brain, the prefrontal cortex, that's where individuals, you know, actually, you know, perform the decision making, they weigh up pros and cons, they do a lot of analysis, you know, process information and situations and so on. All of that in the front part. And that's the yellow part in this diagram. In the blue part is the middle part, the limbic system. That's the area that retains memories and the associated feelings or sensations that are connected to memories. It's in this part that individual human beings grow up and learn to retain information that helps motivate us to eat when we're hungry, to drink something when we're thirsty, because this is where it stays. So the limbic system is where it also retains the memory of a situation that was tragic or traumatic as interpreted by the individual, and the associated feelings are here as well. When you have an individual, let's say someone who has had partner abuse for a long period of time, you know, that what happens is that the limbic system tends to kind of override some of the prefrontal cortex functions. So the capacity to sometimes to be able to distinguish between present day and the past may not be easily done, because the front part of the brain can shrink, and the limbic system is the one that's really writing is really driving the thinking and the behavior. And so I think it's really important to understand that the neurological processes that are involved here are pretty extreme. You know, we could lose function in the prefrontal cortex, and that the amygdala and the hippocampus are in that mid area of the brain in the limbic system. And then when people, like for instance, Kimmy, when she stays on high alert, when she's in that activated state, she is always like ready to be prepared, or always prepared to expect something to happen, to react to it. Or sometimes it could be an underactive hippocampus becomes less effective in making connections. And so when we've had folks who've had maybe a flat affect, when maybe you got 4 or 5 people who respond to, I don't know, maybe respond to a situation, an emotional reaction, like, I don't know, everybody, if you have 3 people who look at a puppy and they go, oh, look how cute that puppy is, and everybody has that emotional reaction, and you have one person who has a flat affect who doesn't feel a thing, who doesn't seem to feel a thing or doesn't react to it. So that is, maybe that's not the best example, but the idea is that the person may not have the capacity at the time to respond in another way because of the impact that the trauma may have had on the brain. The ineffective variability, the elevation of stress hormones interferes with the body's ability to regulate itself. And that's one of the most important things, is when a person is remembering or staying at the high activated state, is the body is not able to regulate, and it's not doing that. So the changes in the limbic system, the neurotransmitters that typically go out to dysregulate arousal and the arousal symptoms system, it's not necessarily there. So what ends up happening also is what I like to suggest that we look at is that when we're working with folks who have had a substance use disorder, or a person who is in recovery, or a person who is still using substances, that the areas of the brain that they're impacted is very similar to the areas of the brain that trauma impacts. So you have the cerebral cortex, but in the limbic system, the brainstem, the brainstem here in the bottom, that's what controls the different functions of the body. And so when we think about let's see, the heart rate and respiratory system, and then the limbic system, which is the brain's reward circuitry, the one where the memories are retained, the association, the associated feelings or sensations are retained. And then think about the front part, the cerebral cortex, where, you know, you can actually do reasoning and you can process information. All of that gets impacted. Those are the same areas that get impacted by trauma. So when we're working with clients and patients within our programs and trying to support them, really meet them where they're at, that's just very, very little in what we're saying, meeting folks where they're at, understanding that some of their capacity, their depleted capacity, may still be present as a result of past trauma. So what happens physically when someone stays at that very activated state, a person's sympathetic system, it really speaks to an autonomic nervous system. So we have the central nervous system, we have an autonomic nervous system. That's the part of our system that helps us cope with situations. That part tends to happen kind of automatically. It doesn't take us to actually have a conscious thought about it. And the sympathetic nervous system's primary function is to stimulate the body's fight-flight response. And so that's hugely important. You know, the autonomic nervous system is supposed to be able to handle situations, but it really depends on where we're at. If Kimi is always in that activated state, she's likely, what's happening with her is that her sympathetic nervous system is staying kicked up on high. And so she's always on that fight-flight, level of arousal. The parasympathetic nervous system is what clinicians or therapists tend to want to activate, because that's the part of us when we go into a situation and we calm down and we reach homeostasis. That's the parasympathetic, that's the nervous system that we want to activate, particularly during times where situations have gone and impacted the individual. And so that restores the body to a calm and composed state. So what is interesting here is that clinicians, when you think about therapists and how they work with folks with extreme trauma and stress-related disorders, what many clinicians will do, they find that a majority of their patients, when they're able to teach them how to regulate their physical sense, their bodies, and get them to kind of learn how to self-regulate and how to calm their body functions, their breathing, their heart rate, all that, with their breathing exercises. When they do that, they're better able to articulate and have a conversation about the situation. And then they can work with them directly. It is a smaller percentage of patients that go into psychiatric care who tend to have the other types of strategies like cognitive behavioral therapy interventions, or EMDR, eye movement desensitization type of approach. Those are more extreme. But the majority of persons with trauma, stress-related issues, if you can actually help them understand how to regulate their body, they're more able to kind of be able to talk through their situation. What we do know is that symptoms are adaptations. There is no right or wrong way to feel, respond to anything, because everyone's very much the individual, and everyone has their own experiences, have their own capacities, their own ideal system, their own way of processing information. And so human responses are normal reactions to abnormal events. And that's really what it comes down to. Any comments, any questions, anything that kind of comes up for you here? How do you think this implicates, how you intervene, how you interact with your patients and clients from what we've discussed so far? What are the implications for practice?
I like that it's literal, meeting the client where they're at, you know, or the person where they're at. So,
Okay.
yeah, it's a literal thing, you know, so physically and mentally and emotionally.
Okay. Thank you. What else? So there's a question. Would you recommend working with them on ways to activate their parasympathetic nervous system? I would if you're trained on how to do the, how many of us, raise your hand in your little box. How many of us are trained to de-escalate situations? So some of the techniques are very similar. So let's just say, thank you. I see all the hands, thank you. So let's just say you're in a situation, you're doing a one-on-one counseling with an individual, and you're doing a session, or maybe you're doing a group session, you're facilitating a group, and one person seems to start to react a little differently. What you want to be mindful of is how they're reacting. Sometimes it's not always a very abrupt, very lively, very hostile, or very animated way of reacting or having like a psychosis, an episode. But there are times where it is a flat affect. They're very much into, they retreat into themselves, or they're not very participatory. These signs, responses that, not responses, behavior that is not necessarily the common behavior you see with the individual. First, it gives you an idea, it gives you a red flag for you, something to explore with. If someone is animated, someone very highly interactive, very animated, and seems to react to something, what you want to do is be able to help them understand how to kind of maybe at least some simple breathing exercise, especially if you're doing intakes, assessment, individual counseling. You want to be able to kind of meet them where they're at. But you guys certainly don't want to feel, I certainly wouldn't ask you to put yourself in if you perceive that you're in danger. If you're at risk, you usually have your own protocols in your agency. There's either a button somewhere where you're going to touch that button and you're asking for support. But a lot of times when someone is having a flashback, when someone is, when someone seems to be very despondent at a given moment, or someone doesn't want to speak about something, maybe they're having a reaction, a nervousness, and an irritation, you want to be able to help them breathe through it. And that breathing is going to help you kind of regulate their bodies, and they learn to do that with you. And they also learn the skill that they can practice on their own. Hugely important. So I'm going to speak to that in a little bit more. I think if you have the opportunities to do that, and I got some information that's coming up that we talk about how we do that. And I'm going to ask you, there's some of you folks who already have experience in how to do that, we can share with the rest of the group. So I would put an emphasis on the client counselor bond. I think it implies I should actively listen to those. Active listening is really takes on even a bigger, more profound definition than what we've always known. Sometimes hearing something that is different than what we commonly hear with a particular person may be the one red flag that we might miss if we're not careful in our listening skills, because we want to be able to explore. We want to be able to give someone the space and the time for them to talk to us about what they may be going through. We think about the different communities, whether it's a Black community, Indigenous people, whether you think about the Asian American, think about the LGBTQ plus community, think about transgender clients that we have, to give them the time and space to let them share with you what they're going, what an experience that came up, particularly if you're doing intake assessment, is hugely important. Part of that is recognizing what some of those signs may be, and we're going to talk about that in a bit. To meet with everyone as though they have experienced trauma. And that's the whole issue here. That's the whole thing that we're talking about. When it comes to trauma-informed care, we want to be preventive in nature. A predominant amount of persons who come into treatment or any kind of disciplines that I have mentioned before, most people with substance use disorder, not everyone, but most people with substance use disorders have had at least one traumatic experience in their lifetime. The timing may be important. Many times it's not one, it's many. Many times you have people who come in who don't know that their traumatic past may be impacting their behavior, but you get to recognize that and give them skill sets. And it's also a matter of being able to help them understand why they have certain reactions. And certainly, of course, and refer to a specialist and come back and work with what the information is that they give your client, and then you use it with yourself, with them when you're with them. And so all of that kind of comes together. It's important, the part that you play. You don't have to be the therapist that cures them or treats them, but you are the person that does have the reason to be preventive in how you talk to them, in the resources that you match them up with, and how you recognize certain symptoms in their interactions with you. So let me go to here. One of the things I will say is those who could treat trauma, before we start talking about trauma-informed care, those who can treat trauma, treating the trauma experience really uses a certain processing, therapeutic interventions, and that's for folks who are trained specifically for that. But in terms of you folks as providers, if you don't have that other capacity, you can also help recognize the symptoms and help folks understand how they can regulate. And so, but it's really important to understand, kind of stay in your lane, so to speak. You don't want to get so deep that you want to have a discussion and where you start using therapeutic interventions, and if that's not your capacity, just kind of like know what your capacity is, and understand that in trauma-informed care, it's really about being preventive. It's an adoption of principles and practices, first, that you promote a culture of safety, empowerment, and healing. And so that is all fundamental to the preventive approach that we're going to talk about. Any comments, any more comments or questions right now? So, okay, we're going to bypass all those questions that you have right now. we're going to take a 15-minute break. Okay, everyone, welcome back. Laura, I saw you with a cup. I know some people like tea. Tracy, you got tea?
I'm all about coffee.
Yeah, it's tea. It's tea. It's tea. Ginger tea.
Tracy with tea, Laura with coffee.
Yeah, I spilled some on my shirt.
I inhaled mine, caffeine, the coffee. I don't know. It's just kind of, I never used to drink coffee until I got into the field.
That's funny.
That'll do it. So I have a quick, Mickey, go ahead. Yeah, I see your hand up.
So I was just letting you know that I did send his name and who he's with in the chat box to you.
Very good.
And then I know we had another one too that was also doing the Zoom on with another person, so I'll have her message you as well.
Can I see can I see them on camera though?
Yeah, since I was on the phone right now, but once he gets in here, I'll have him get on the camera so you can see that he's here, and then I'll let the other ones know the same thing.
Well, thank you for bringing it up. So one of the things before I go back to the materials, I wanted to ask, how many people are seeing trauma with the communities they're serving? You raise your hand or, okay. Excellent, okay. Next question. The next question is, how many folks are working with communities of color, transgender, gender diverse communities, and or impoverished people who live with the income below the poverty line? Okay. All right, so when I mentioned race-based trauma, racial trauma, and the other stressors, I didn't mention social determinants of health, which has a huge impact on any given individual you work with. Hugely important. So we have some, so I'm going to put a handout, and I know Tree, my colleague, is on here, so we will be able to send this to you with the slides as well. So what I wanted to say here is that we know that the prevalence of trauma is more prominent the prevalence of trauma is higher with communities with substance use disorders. We also know that the prevalence of trauma is it's also high amongst communities of color, amongst the non-binary populations, amongst people who live under the poverty level. You know, we're talking about the traditionally underserved communities. They also tend to have high levels of trauma. Also, folks who are from any background who are also dealing with co-occurring disorders, you know, and other, you know, think about social determinants of health, other challenges in their world. And so for the most part, we are all working with people who have a high prevalence of trauma, period, across the board. So I gave you that a handout to help, but also I'm asking also, I'm also kind of working towards why we need to be preventive and how we go forward. Everyone that you're working with and all of us have survived the last 3 years. So whatever may not have been there tends to be present now. Whatever was present before has been exacerbated. So it's at higher levels as you may see now. So when we were talking about and discussing the potential reactions any given person might have from a past trauma or series of traumas or recurrent trauma. So we were talking about what the signs look like. And so can look like rather, and everybody's not going to respond the same way. And so where does that leave us? That's where we talk about trauma-informed care. And so there are various things that we can do. So when we think about it, I just want to go through trauma-informed care in terms of what the principles are, and then we're going to talk about how it applies in the different processes that we facilitate with our clients. So here, according to SAMHSA, and SAMHSA funds most of our programs, a lot of our programs, the concept here is it's really spoken from a comprehensive perspective, from the organizational perspective. And that is a program, organization, system, and even individuals who are trauma-informed tend to realize that there's a widespread impact of trauma and understand the potential paths for recovery. And so potential paths for recovery, when we think about the recovery perspective or recovery-oriented systems of care, that is a perspective in terms of recovery. It really depends on that individual and what they identify as recovery. It also works, it also is also contingent upon what we define as recovery as, or the goals of recovery as an organization, and what systems we may have in place to understand that there are different, to help support the individualized processes for each given person. Meeting them where they're at means that everyone's process will not necessarily look the same. Really shouldn't look the same. Should be very tailored to that individual, their capacity, their strengths, and their definition of how they want to move forward. So we realize that trauma is very prevalent, and it'll impact the potential pathways of recovery. Also, we recognize that there are signs and symptoms of trauma, and it's not just in clients. Sometimes we see it prevalent, we see the reflection of it in families, in communities. We see it in each other a lot of times, and how we respond by integrating trauma, about responses, reactions, understanding how it can be very individual and what it might look like, and how we integrate them in policies and procedures and practices. I mentioned the idea about when I have a situation or where I'm having a confidential one-on-one counseling session with a client, and that button, and that was because one of my past career moves involved when I was working in prevention, and this is really a prevention delivery. When I was working in prevention, I had a client who seemed to have a psychotic episode at that time. The desk was strategically situated in the room. As a provider, I had the door access. It was very easy for me to access it. We had a system where we had a button where we were trained on the protocols in terms of what constituted a potential emergency, where we could hit the button. And I had a situation with a client one time where we had a really good rapport. He was very committed to following through on different aspects of what the program required. And he had an episode, and he started to get very animated, and I had not seen that before. And so between that and his animation, and at that time he was speaking to someone who I knew for a fact had already passed away. So he had symptoms of schizophrenia, but I did not have that as a diagnosis. It was not part of his documentation. So I don't know, we had a a stress-related situation he had just dealt with. He had a history of being transient, so there were different factors that caused me to say, okay, let me hit the button. I don't know what's going to happen. It wasn't just that I would be at risk. I really thought he might hurt himself. And so I had a button. So we have to be familiar with what those protocols are in our organization, what constitutes a potential situation where even a person may have an episode where we may think they may need specialty care. He ended up going to the emergency room and it was addressed and then he was let go. The idea is to understand what your processes are, what your practices are, and not re-traumatize any given individual. So trauma-informed approach defined is really a strength-based service delivery approach that is grounded in the understanding of how we are responsive. Our responsiveness in the context of trauma with any given individual. It emphasizes the physical, psychological, emotional safety. That's not just for survivors, it's also for providers. And so it creates the opportunity for survivors to rebuild a sense of control and empowerment. And we know as providers, we always look to safety first. And so the 6 guiding principles of trauma-informed approach and based on a strength-based approach. It starts with safety, and that's really throughout the organization. It's the space, it's how staff interacts, the tones and the mannerisms that we interact with different clients, and to create a physical and psychologically safe environment. And so the environment itself, when someone first comes in, as well as when we are engaging someone on a one-on-one in a confidential and a private space. So it's also about trustworthiness and transparency. So different organizations have operations and decisions that are conducted, and we as professionals do everything. We're supposed to be transparent with our clients. No surprises. Surprises can be triggering factors, and so we will always try to be upfront right at the beginning and let a potential client know these are the do's and don'ts, kind of the expectations of the program, and what they and us can agree on as we move forward. So being transparent, not coming up with surprises, not all of a sudden coming up with something that they didn't expect, that wasn't part of what they can expect, and then we actually lose and impact the ability to be trusted. And so our own trustworthiness is really part of this as well. Can they count on our word? Can they count on we're going to do something, we actually follow through, or we forgot, or we didn't come in that day? How that impacts them. So it's also important for peer support, which is really, really important. And it's part of how you build trust and establishing safety and environment. And peer can also, this was developed first before peer support specialists were actually recognized and officially and formally become an actual professional opportunity. And it's been a hell of a movement because it's helped us engage and really mitigate a lot of issues with different clients that we work with. So peer support is also think of it in a literal sense with peer support specialists. We have them on board. It's really helpful for clients to be supported in that manner as well, not just by us as providers. The other thing is collaboration, mutuality. It's a recognition that, this happens, this is what you want to establish when you initiate a rapport, and what you want to build on is that you can support someone where they're at, but you also help assist them in their decision-making process, giving them information or the opportunities, and they can make informed decisions. And so how that works out, it's really about recognizing how also trauma might affect what they decide on, what they don't decide on. It's not about what we want to do for them. It's really about supporting them where they're at, and so within their capacity. And so it's also, empowerment and voice and choice is really important. They should be an active participant in their treatment and recovery process. And cultural and historical and gender issues. This is something I don't think we talk about this enough. We do so many things that you're attached to doing in terms of the clinical processes the documentation you have to gather, the instruments you have to use, the clinical processes that you have to adhere to with fidelity. Totally understand that. But we also have to consider that there are other aspects of humanness of that person that we're working with that our clinical tools may not capture. So what are the cultural aspects of that individual? Who are they? How do they identify? How does that impact how they interact with you? The historical references I've mentioned about historical trauma or intergenerational trauma? Are they identifying with a community that has been, that historically is oppressed, and most people, most communities of color have that history? And so, and then you have to consider, you know, the current environment, the environment we just survived in the last few years, and then the current environment, what it looks like for them. Understand how that may be, is there something to explore, how that might impact their ability to actually achieve some of the goals they want for themselves, maybe follow through on some of the resources that we're providing for them. What are the gender issues or non-binary issues that may be impacting some of the resource matching, or maybe some of our interactions? So all of these are principles of what we take with us and how we practice trauma-informed care. And so let me just get a little bit more specific. So clients with trauma, what do we do? So part of the opportunities we have is we use empathy. So we put ourselves sometimes in the shoes of another person. It's stronger than just sympathy. It's expressing a feeling of sorrow for another person is one thing, but being empathizing with someone is pretty much at the core of what we do. Some clients need to briefly describe the trauma that they experienced, particularly in the early ages of recovery. I would tell you that if someone is able to share with you their situation, if they feel comfortable enough with you, that's an opportunity you want to build on. So find ways and means to be able to provide them the time and space to hear someone out. When you interject and cut someone short, that's a great way to lose a particular a rapport that you may have been building on, and it really is going to impact whether or not you're going to have an effective alliance with that person. When someone is ready to share about the experiences they've gone through, that can be hugely empowering for them. Especially if a lot of times we don't know that person is not at anyone they felt comfortable enough to trust to talk to. A lot of people will not necessarily speak with their families. Some families may not be as aware of how traumas can impact people. They may not be comfortable. They may not have the support system. They may not have anybody in their life where they can share this type of situation with, or who would understand. And yet, if they come to us and at some time they start to share about that, give them the time and space they need to do that. And then also educate them on how to normalize trauma-related symptoms. And we're going to talk about the breathing exercises. Identify and explore strengths in the client's history that can help the client apply those strengths to their ability to function in the past and in the present. And so many times, a lot of the folks we work with have had opportunities to resilient coping skills that have helped them process through situations and resulting feelings. And so I would think of it like a recovery support specialist might want to tap into their recovery capital. We as providers, we want to tap into the successes or opportunities or strategies they've used in the past that has been effective or successful, so they can use it in the present. Sometimes reminding or listening that and reminding them of that can be really super supportive. So consider, for instance, also using a trauma lens. So a trauma lens is a little challenging for some of us, and maybe to look at things, to look at behavior and not to have an instant assumption from it, and to look at it from a different perspective. So for instance, if a treatment program that serves meals, this is just a scenario. They include entrees that combine more than one food. Your client enters this program, refuses to eat. The dietary staff explains that food choices are limited. I've had clients where they start their processes. They have detoxified. They are in residential treatment, and when they come into treatment within several weeks, they have a hard time eating. They don't eat certain foods. And I've heard where other folks have said, well, they didn't care about what they were eating when they were using. Now they are. Well, this is the type of thinking, and I'm thinking that we could challenge ourselves with. When we use a trauma lens, someone is not, and someone is, had the substances are down, and they may be dealing with the things that maybe they used over, maybe the things that they've forgotten, they've intentionally not addressed for a long period of time, because maybe addressing them or remembering them brings up feelings and physical reactions they don't want to deal with. That's potentially possible. And so initially you might perceive that the person refused to eat or avoid certain foods as an eating disorder or behavioral problem. A lot of times folks will go to behavioral problems. What we can do is try to look at it a little differently. Using a preventive approach in our lens, we may think about a trauma-aware perspective. So challenge our own assumptions by considering that maybe this person in the past, now substances is not part of their world. They're trying to recover, they're learning to do things without substances in their life. And maybe some things are coming up. For instance, what if that person had experienced during childhood, neglect and abuse? Maybe they were forced to eat certain foods that, maybe had combined everything in the refrigerator, and they were forced to eat that. Maybe those situations were traumatizing. One of the things that happens often, and we're not always aware of, is when the substances are not indulged in anymore for at least the first several months that someone's in the program, we don't always necessarily view particular behaviors as the things from the past coming up. And so this can be a really good sign, something for you to explore, for you to acknowledge and explore with that individual to find out where that may be coming from. So using a trauma lens is really more preventive, really instead of challenge your assumptions by eliciting information. Let's see where that's coming from so you can better help that person. Does that make sense for everybody? I see there could be a correlation with a trauma and specific food. Yeah. So who here hasn't had a food when you were young was there a food that you ate that you really disliked as a young person? I could tell you one. I mean, I had physical reactions and everything, but I was still forced to eat it. I don't have any trauma issues behind it. I just don't eat it. But for someone who's just coming into our program, especially early on in the first few months, many things come up. In a way, what happens is that the substance use covers a lot of things for a long time. So it nullifies quite a bit of symptoms and memories for people, and that helps them kind of get past it, and then they get caught up with the addiction and end up meeting the criteria of substance use disorder. So when the substance is no longer part of their life, these things come up. They are uncovered. And so that's our opportunity. Because when we see it, let's explore it. Let's elicit information. Let's ask about it. Let's see where it comes from. And then we tailor those eating habits, make specific nutritional requests, because it's really important for that individual, because nutrition is a big part of how someone recovers. So yeah, we can consider that. We can consider that. If they had traumatic issues, then those are likely going to be linked to other situations that they may have gone through too. So these are good red flags for us to recognize. So what I'm going to do is, and is everybody feeling all right? I haven't said anything too graphic, too drastic or anything. Okay, good. So it's a safe environment. So, and still I want to remind you that if anything kind of kicks up, please take care of yourself. So I want to show you a video. And I'd like you to kind of hear some of these, and then I want to get your feedback on it. You as providers, say if any one of these folks end up being, or may have been a client of yours, I want to get your feedback on it. So I'm going to play this now.
I felt so trapped and so alone. I felt so ashamed, and I grew up with this saying, you made your bed and you've got to lie in it. And so I kept telling myself, well, I made my bed, here I am, now I've got to lie in it. And this is my lot in life. This is what I got myself into, and there's no way out.
I kind of thought it for years that it was my fault that I was that way. Maybe I looked at the guy that molested me. Maybe I smiled at him too much when I would be at my friend's house.
I feel responsible a lot for my mom being angry at us when we were kids. Sometimes I'll say, you know, if I just had been a little bit quieter, maybe, you know, she wouldn't have beat us.
I didn't care about myself then. Like, I had no self-worth, no self-esteem. Back then I didn't care if I lived or died because I didn't see the value in me. Like, I didn't feel worthy of anything, any love, or I just didn't feel like I was important.
It stems from that core belief that's put into you that you're not good enough, that you don't count, that something is inherently wrong with you, and therefore you're not qualified to deal with whatever's going on.
I had a hard time sleeping. I always startled really easily, and I'd wake up real easy, and I'd wake up afraid with an adrenaline rush. So I had a hard time getting asleep and staying asleep, and I still have occasional nightmares.
I always keep the television on because of the fear of darkness and the fear of sound. I'm still not ready yet to turn that television off at night. I need to, when I open my eyes, I don't care when it is, I need to see. And I'm never in a full sleep ever because I'm always in ready mode. I'm always in fight mode.
Walking in big crowds like at the airport or in the metro system, stick close to the wall so that people won't touch me.
I have to be really careful where I'm at, what I do, how I sit. I don't sit with my back to the door. When I'm in a store, a grocery store, and someone has come up behind me and they get into my space where they're really close, I have turned around and punched them or pushed them physically, you know, and dared them to hit me back in some way. I don't care how big they were. I don't care if I get the pulp beat out of me. The issue was, don't get in my space.
If you say anything to me, there is something that I gotta sit back and watch. I really can't trust you no further than I can actually spit because of all the hurt and the trauma that I dealt with throughout my life.
At times it's really hard to trust people just because I know that, well, from experience growing up, people aren't always there. They betray you. They hurt you.
I had a hard time sitting, and still do, with my back to a door. It makes me really uncomfortable because I don't want somebody to walk up behind me. I feel like somebody's gonna come up behind me and do something.
The transition back in the community after coming out of prison was kind of rough because of the paranoia, for one thing. And like I say, you always think, because you got to stay on guard in prison. I don't care how tough you are, you know, you have to stay on guard. And when I came home, it was just, I thought everybody was out to get me.
Fear dictated everything that I did. I always wear several pair of socks, and I always have shoes on from the time I wake up to the time I go to sleep. And it's a preparedness, you know. They'll say, why don't you ever take your shoes off and relax? Because you have to be ready.
I have flashbacks all the time. And that's one of the major things that I'm still working on today because some of the things is just too real, even today. And that would happen 35, 40 years ago. And yet I can still see it right now before my very eyes. I can see it. Sometimes it messes me up so bad.
Panic attacks. We couldn't catch my breath. I had rapid heart rates and sweaty palms. Sometimes just seeing a place or seeing a person or seeing an incident or smelling something could bring on that panic attack because all of a sudden the memories come flooding through.
Some of these things I still experience on a day-to-day basis. The numbness, the memories, unexpected triggers, you know, sights, smells, and sounds. For me, panic attack is, of course, all the things that people typically describe: heart racing, short breath, feel like you're gonna die, can't get out of it.
The TV being on is not something I have in my house. It's the TV going on when I'm in another room. Because the TV was always gone on those days that I would be in Oakland Hills with those guys. That's what was playing in the background as they were just having, you know, their way with me.
Sometimes somebody can be just walking past me and I'll flinch and jump back and they'll be wondering, what the heck is wrong with you? You know, but they don't realize what's going on inside my head.
It's hard to explain when you drift away and then come back. I just know I could be talking and then the next thing I know, I'm just in another land.
Like I can probably go through half of my day and not know what happened because I've been somewhere else in my mind, in an alternate, I call it an alternate reality, especially when I'm in situations where I want to remove myself. I can just send myself somewhere else mentally.
I cried if I just thought of anything. I've cried just being lonely. I cried because things didn't come out right. I cried when I just thought about everything that happened in my life. I didn't want to be bothered. Didn't want to go anywhere. It was just work, home, in my room.
I can't untangle from the depression. I can't separate out the depression from the substance use. It's all just part of who I am, I guess.
I just wanted to kill myself. I just wanted to die. I figured, well, if I die, I don't have to have another person touching me. And if I die, I don't have to hear something in my head telling me how awful I was and that it was my fault. And if I just die, then maybe the world will be just a little bit better.
With the cutting and the burning and hurting myself, doing what I call self-mutilation, that was connected directly to trauma because I was trying to control internally what I could not control externally. So when I would get triggered or, you know, by an incident that happened outside, I would cut because feeling that warm blood, the warmth of it sliding down my arm, for some reason that made me feel alive. I was just angry and fearful and hopeless and helpless, and everything was about me hurting myself. Hurt people, I hurt myself a lot.
The thought of being harmed or being in a risky situation, like I didn't have any kind of filter about that like most people would. I also started acting out sexually, and so I was sleeping with older guys. I mean, I was in the 4th grade and I was sleeping with guys that were like in middle school and high school.
High-risk behaviors was really just kind of how I functioned. I was violent. I would take on a man 4 times my size for looking at me wrong in a bar or making a pass at me.
I didn't know what danger was. If somebody had some dope and said, look, come in this alley with 5 strangers, they was like, come on in the alley, we're gonna get high, you know. I would go, that wasn't dangerous to me. I mean, I intentionally sought out people who were gonna hurt me. Going to emergency rooms, beaten up, in the emergency room, nurse looking at you, you back? How you raped again? Weren't you just here a couple months ago saying you had been raped? Because I didn't know the warning signs, and I would put myself in harm's way.
I am very hypervigilant. So hypervigilant, what that means for me is that I'm always paying attention to everything around, and it gets tiring. And I think for me, heroin just relaxed that. Just relaxed that place in me that is always wanting to, you know, get into something, do something, be something. And so I could just be with what is, always wanting to beat somebody up or prove something to someone. The drugs really help calm that.
When I was on weed, everything was all right in the world. Everything could be falling down around me, but everything was okay. I was cool. I was mellowed out. You know, all my problems seem to go away, at least until the highs start going down. That's when the reality started coming back. But I just medicate myself with more weed.
Everybody betrayed me. I just felt like if I drink, I'll drink it all gone.
When we start to recognize some of the symptoms and some of the reactions that clients are having, that may have implications for different processes that we engage in them. When that gentleman was talking about where he gets lost somewhere in his mind, and sometimes, or was it, no, the woman was talking about how she sometimes gets lost in her mind and involved in those experiences and the memories of them. And sometimes time can pass. So when we think about when a client does not show up for an appointment, maybe more than once, what else may be going on? This can have implications for how we interact with them and how we set up different appointments and match them with resources, expect them to come to group and have certain interactions with us. So think about that. Also, what do you think? How do you think someone who might internalize guilt behind the abuse that they got, let's say they share that with you, okay? What do you think can be a potential impact on their on how they adhere or how they interact with you in the program? Or what part do you think it may have played in substance use or the co-occurring disorders, or the recovery process, when it might, what challenges does it present? Someone feels guilty behind them having their own, all that abuse. Jen, I see your hand up.
Sorry, I was trying to unmute myself. But one thing that I did see in common with a lot of the people that were speaking in the video is that in the initial part, they did kind of go over, you know, different sort of reasons to put blame on themselves for some of the past trauma that they have experienced. And I also think that that can kind of be an obstacle for them for sort of like certain behaviors that they have learned to cope with the trauma.
Yeah, thank you, Jenna. It can certainly impact their commitment to their own recovery process. So so what I think it does help us also is for when we recognize that is how patient we may have to be. So when I think about clinically, we have program structure, certain amount of time, the folks expected to be in our program. Guess what? That person might need more time because certain issues may be affecting their process, or their progress should not be measured the same way maybe we measure others. You know, so some things to think about so we can mitigate those different factors to help support that person, wherever they're at throughout the process. There's potentially you can work with a lot of clients, clients who have trauma issues who are in clinical care, in therapy, and be able to mitigate between that and use your preventive approaches and giving them time and space to help support them where they're at, and also align it with the therapy that they're getting through specialty care. But it's really important to understand that how someone feels and someone where they're at can certainly have a specific effect on the different things they do, the decisions they may make, why they may not show up at an appointment, you know, what they're wanting to do today, but sometimes can't. So thank you. I feel guilt can present in recurring relapses or recurrences. Yes, I certainly thought about that. I thought that how guilt can do that. Sometimes it's not conscious. I don't want us to forget that much happens subconsciously, particularly with people who have substance use disorders. And so when you get to the point when the person gets to the point where they meet the criteria, and there's relearning how to process information in a healthy way, there's certain things that kind of happen automatically. So if using substances was part of how they dealt with the low self-esteem issues, or the fact they couldn't meet role expectations, or they felt they weren't good enough to do certain things or play a certain part in their life or in their family's life, that guilt can be part of what helps someone actually get back into relapses, you know, maybe more than once. Hugely important for us to understand that. You know, let's see, the guilt about what happened to them may not feel like they deserve treatment. And when we think they may not be as forthcoming or as committed to their process, it may not be a conscious thing they're doing. It may be connected to their trauma. So it really challenges our assumptions and our expertise of what we think we see all the time. Let me see, there are times when I feel there is more to the situation. So something I always think about when it comes to the clients and patients we work with, there's a lot more than meets the eye. Always. When it comes to trauma, knowing, because we're all aware of how prevalent it is, almost always it has something to do or it intersects with the other issues they present with. So let me go back to this. So the cognitive triad of traumatic stress, in terms of cognition and trauma, experiences affect and alter cognitions. And so it also affects how their perception of their world, of their environment, of themselves. So the views of self, and some of it you heard in the video are, I think, speaking to like, I am incompetent, I should have reacted differently. And sometimes these very perceptions, even though someone tries to be in a program from their own, their own choice, they're actually not able to commit further if they internalize guilt to that degree where they don't feel they really deserve to treat, they really deserve a shot at a different way of life. So it's too much for me to handle. I feel damaged. Views about the world is a dangerous place. People can't be trusted. So someone can be very reclusive. Somebody can be very dismissive. Someone can be very quiet and not participate too much in some of the groups. Kimmy's case study really spoke about how about life's unpredictability. Not necessarily that life is unpredictable, but that she was expecting that. And so views about the future, we like to motivate our clients, or we want to incite that motivation. And it might be difficult for some folks to get there, might take more time than other folks because their views about the future may be different. Things may never be the same. What's the point? Feeling hopeless. Carla, please go ahead and share with us.
Thank you. So I really appreciate this conversation and all the information has been given in how individuals who have experienced trauma may, some of the things they may experience when they come into programs. One of the things that I often think is many times in the programs that we work with, the people that are providing services are trauma survivors themselves. And I'm just wondering if, oftentimes in this type of programs, especially, I'm referring to a domestic violence shelter, which is where, my interactions take place. Oftentimes individuals have not had the opportunity, not just to be diagnosed, because that's not an opportunity, but they haven't had the opportunity to become familiar with the symptoms and really process where they may come in from and their reactions. And so when they come into places kind of like at the beginning of the journey, right, what we find is that despite all this information about trauma-informed care, is the staff that is having a really hard time in coping with these individuals. And oftentimes it may be the staff themselves that are being triggered by some of the behaviors that individuals that are displaying in the programs. And so I keep thinking, like, how do you change this? Because does that falls 100% in the organization? How do you prevent this? It's almost like a vicious cycle, where you're having this information, but yet how do you support these individuals working in there so that those adverse reactions to behaviors or comments or looks are not showing up in the workplace? Or how do you support them so that it's not as bad for the clients that come in? You know what I mean?
I do know what you mean. And I know you're talking about the provider perspective when providers themselves are dealing with their own trauma or not aware that they have their own trauma. So one of the things I mentioned early on, so there's a couple of things here. One of the things I mentioned early on is about your ability. First of all, I said, everyone here, your own personal trauma can come up. I am not dismissing anyone. I think all of us have had some experience with it. If you didn't before, in the last 3 years, you had something. So if you felt something, you have some kind of maybe reaction or response to different traumatic situations that we were just experiencing the last 3 years. When you're working in this kind of field, one of the things we do always make sure that we provide you is that your ability to be self-reliant, so your ability to have emotional regulation, to be grounded in your work, has to do with you addressing your own issues. Acknowledge within yourself your potential issues. You're human. That's part of what the beauty that you bring to the work that you do and how effective you are with people. But you also go through your own situations or have gone through your own situations. So there are things you can do. You can actually even just assess yourself. Organizations can do it from a certain perspective. You know, they can provide you support, but you folks yourselves, there's a 5-scale questionnaire that I use in a particular other training that is really helpful for providers to just look at and be able to kind of assess themselves where they're at. If you do the self-introspection, the self-reflection every once in a while, you're working with people in the communities, that is supposed to be a healthy activity that you engage in. It's that periodically, every week or every other week, that you actually look within yourself. How are you doing mentally, physically, and spiritually? What's your health like? Because that's the person you bring to help other people. To bring yourself as grounded as you can, you want to be able to resolve or address issues within yourself. So recognize that sometimes, you know, in your humanness, maybe you're processing certain things. Maybe you just had, a lot of us have had to process loss of life, and often in very traumatic ways. And it hasn't been just a pandemic. It's the pandemic. We've lost people for opioids, overdoses. A lot of us have recovery families and people in recovery that we know of. A lot of us know folks who may have been in an accident. Or people who, knowing somebody goes into the hospital and doesn't come out. We've all had these different situations, and maybe our own traumatic issues come up. There is there's a 5-point scale. If I'll get it before we log off, and I'll put it in the chat box, and my colleague Tree will also send it out to you with the materials when we finish, or when you get your certificates within a week or so. And so what you could do is just look at where you're at first. Well, for us to be able to see someone else clearly, you have to see where you're at. Recognize and acknowledge what's going on. And there's this information you can apply to yourself. Provider self-care is so important. You have to take care of yourself before you can take care of someone else. It also provides you a lot of experience that you can share. It's not just the recovery support specialist uses lived experiences, but the strategies that you use to help yourself are strategies that you can use in service for folks in the community. So they're very strength-based, and they acknowledge your own humanness. It's not a deficiency of any kind. It really speaks to how the caring people that you are. So it's important for you to use that. I have a 5-question scale, and I will put it before we finish today. So look at yourself first so you can see the other person a lot clearer. Because what you don't want to do is take a risk that someone's story triggers your own trauma, and then you're not present there, you're present in your own issues, and that person loses the opportunity of the support from you, and then you get caught up in your own issue. And it's happened. We've had issues of transference, county transference. We've had issues of folks who have had an episode out of nowhere because they didn't resolve their own issues. They didn't even acknowledge. So even acknowledging is a great first step. It's a great first step, because if you can acknowledge your awareness is about making sure, okay, this is what I got, but I'm not going to let this be part of the process because I have to help Maria, or I have to go help Henry, and that way you're in a better position to be of support. But you can also use some of these same skills for yourself. So let me give you something before we end. So thank you for bringing that point up, Carla. The truth is, we are affected by the communities, but we're also affected because we live in a lot of the same communities. So acknowledging our own potential challenges will help us be more supportive for the clients that we work with.
So piggybacking off of what the young lady said, I'm a drug and alcohol counselor, in which I do deal with co-occurring disorders. Mm-hmm. And what I have found, based on all in your information today, is marvelous. But what I have found that works for me, at the end of the week, I do some self-reflecting in regards to how I managed myself in reference to the service that I had to provide that week. And also, I also like to self-reflect, because then that way it allows me the opportunity to see myself, okay, as to the manner I was moving, and hopefully look at myself in a way where I can give some improvement.
Thank you, Jackie. I appreciate that. So I would say self-reflection is great. It's really an important activity. So if you can get in the habit of doing that periodically, it's healthy. The other thing, and I don't know if we're going to get to it today, but the other thing about self-care is disassociate or cut the ties to your job, and don't forget to participate in your life. That also, our psychological welfare is so important that we have to have other activities that has to be retained in the limbic system. It can't all be depletive information because we're helping someone else. It has to also be things that are important to us. So what are the hobbies that we do? Do we like to read? Do we like to engage with other people? We are able to be in person these days. You know, I know life-work balance is very important. So balance for me is a challenge. It depends on the day. If the moon is out, who knows? You know, what are opportunities? What are, you know, my responsibilities versus my obligations? But it's so important, you know, that you actually do these things that are important to you, that speak to your spirit, to who you are, what, you know, things that you like to do on the side. Maybe you have some skill sets. Maybe you like to work in community. Maybe you like to paint. Maybe you love karaoke. Maybe you love music. You go into a book. Whatever it is you like to do, not to dismiss that. That helps to let me use the word, that helps to balance out some of the impact of the work that you're doing and the effort and the support that you're giving to the client community. Psychologically, that's healthy. So it's important that you do that as well. So thank you, Carla, for bringing that up. And that's part of how we become, or we are grounded enough to be in a position to help others, because we actually do that for ourselves too. I will always say it begins and ends with us. So let me go into here and let's talk about just a couple of things. In terms of like assessment, like, so some of the things to think about when we're doing screening and assessment. So I'm always mentioning this. It's really important to understand, to help have an environment that physically and cognitively will create a sense of safety for any potential person that you're working with. We're not expecting that everybody's going to present with traumatic issues or trauma symptoms, but we want to use a preventative approach, which is foundational to trauma-informed care. We want to make sure that that space feels safe for any given person you work with. There's a lot of questions you're going to be asking that's going to help and create that atmosphere. When you are not just physically, but when you are approaching someone and the way you approach them, that's hugely important. So provide an opportunity for individuals in trauma to successfully self-regulate their behaviors in productive ways. It can create a sense of belonging. And so there's some breathing exercises that we can do. Install routines and schedules and structures and rules that are predictable, and allow the individual to establish a sense of competency and achievement. One of the other principles within guiding principles of trauma-informed care is voice and empowerment. So they can play an active part in which structures or which activities you are hoping they engage in, which ones are doable, realistic in their world, according to their capacity and their own other obligations. So their voice in this is so important. I'm going to ask a volunteer to read this.
I'll read it.
Sure, please. Thank you.
From the first time you provide outpatient counseling to Jay, you explain that he can call an agency number that will put him in direct contact with someone who can provide further assistance or support if he has emotional difficulty after the session or after agency hours. However, when he attempts to call one night, no one is available despite what you've described. Instead, Jay is directed by an operator to either use his local emergency room if he perceives his situation to be a crisis, or to wait for someone on call to contact him. The inconsistency between what you told him in the session and what actually happens when he called makes Jay feel unsafe and vulnerable.
Thank you so much for reading that. So what's your take on this? How do you think this is going to impact any potential rapport that you may have had with this individual?
I think it might lead to a breakdown of trust. He might shut down and start saying, I mean, it depends on his feeling, but he might start not believing anything that the provider says.
Yeah. Yes. And how receptive do you think Jay would be going forward with any suggested opportunities that you might have for him?
Yeah, he might be less suggestive.
Yeah. And so, and we don't know and can't assume that trauma doesn't play a part here. We don't know that, but it can be. You know, but whether or not it doesn't, you know, it really speaks to us. You know, the weirdest things can happen in our lives too. We're human too. So, you know, what if for some reason we didn't follow through on some activity we said we would, and because things happen in our lives too. So it's really a matter of how you go back and you re-engage Jay and say, would this happen? And I apologize, and own up, you know, own up your part, because if he has a trigger, has a reaction to feeling unsafe and vulnerable where it impacts your dialogue going forward, or your interactions going forward, you want to be totally transparent, totally honest with them, so you can reestablish that rapport and let them know what this is what we're going to do going forward. So just in case something happens to me, and this way, so he can understand and see the human side of you too, not just that you're a provider, a personal authority, or your counselor helping them, but also see that there's another side of it, you know, and he can know that there's, and you can also learn, all right, what would be a backup system or protocol that can happen in case something like this happens again. He can rely on someone, so he does feel safe and vulnerable. So these things can happen for an array of different reasons. So creating safety, introduce yourself in a congenial and inclusive manner, always do that. That's part of how you create that safe space for someone. So whether you're introducing yourself with your pronouns or an inclusive, some kind of inclusive introduction, for everyone, so that way if someone is non-binary, they also feel like, you know, they're comfortable in how you introduce themselves. That can start to create a sense of safety for that individual. Provide culturally appropriate symbols of safety in the environment. You know, when you are reflecting the cultural aspects of the communities, that type of representation that we have as providers of different backgrounds, and also in our physical environment, can help create a sense of comfort and, you know, and hopefully safety with a given person. Space privacy with the client, understand what that's like. You know, it really depends. I've had clients where after a while they become very comfortable, they get really close, you know. And then I also know that sometimes I know that there are some folks who will keep a distance, respect that space. These days, a lot of people might be still practicing social distancing. You know, we still practice it at Columbia as colleagues. So many people may have gone through a heck of an experience the last 3 years where they see the benefits of distance. But some people might get comfortable and might get up close. And so understand and negotiate that with the person. Explain confidentiality. Don't assume they understand what confidentiality is. You know, use your communication skills. Have someone kind of repeat back to you what they understand of confidentiality. It doesn't mean and look the same way in all different social services settings. Clarify what to expect in the screening and assessment process. Don't, when you explain or frame a particular, you know, data gathering protocol, whether it's intake, screening, assessment, you know, you want to explain these are the types of questions that are coming, because a lot of times you have to read them verbatim, frame them, or help them understand this is what it's for. So I might use words like these because I have to read what's here. Let them know what's coming so they can start to get comfortable and understand, oh, this is how you interact with them. This is how you do your professional services. That can help them feel comfortable. So and follow their lead. They're also being aware of their own emotional responses. It's not just always verbal. Sometimes it's physical. We're going to talk about that now. So we talked about space and also the opportunity for storytelling. So ask all clients about any possible history of trauma. there are certain tools that are out there that you can use as a checklist to increase proper identification of such history and helps you understand how to ask the questions. There's one that says, that speaks to actually the ACE study, and it gives you specifically developed questions. Use only validated instruments for screening assessment. When clients screen positive, also screen for suicidal thoughts and behaviors. Do not delay the screening or wait for a long period of time of abstinence or stabilization of symptoms. Would help anybody you might think they would need now. Be aware that some clients will not make the connection between trauma in their histories and their current patterns of behavior. Sometimes it is psychological, that they don't have the capacity to be able to do that, to link it. Maybe at that time they are not ready to see that. So that's why I'm always leery about the word denial. What we see is not necessarily a truth for them, but for us to meet them where they're at, we have to understand things from their perspective. So it may take time. It may take a little education from your part to help them understand, or help a group understand how trauma can impact thinking and behavior before a person is ready to see that connection. And then also, don't require that a person has to describe to you any traumatic events in detail. A lot of times, just, maybe all we need to do is just focus on trauma symptoms. When someone is ready to share with you about details, that's great, and they can share with you. And sometimes they're not. Sometimes some folks will speak to it and just kind of go over it and then get past it in the conversation without going into detail, because they're not in a place where they're safe enough or help or feel comfortable enough to speak about it. But acknowledging and recognizing it on your part will give you the opportunity that you will be able probably to explore it a little later. The idea, what you want to understand is, are you seeing any kind of symptoms while you're asking these questions? Are there any reactions that seem to be happening? So talk about how you will use the findings of these, how you use this information to plan the treatment and discuss immediate action necessary. It's interesting how I see some settings, they ask for a certain specific question, they elicit the question, they gather the data, and they don't do anything with it. It doesn't make sense. Use it to inform how you move forward with the individual. It would help you understand how to interact with them, what questions to ask. It'll also help inform what resources that may be viable options to help address the different issues that they present with, and which ones may not be the best. So the readiness to leave can be assessed by checking on the degree to which the client is conscious and in the current environment. If someone is having an episode, that's not the time, because the session is over, it's not time for them to leave. It's really about ensuring that they are present in the moment. And so part of that is, first of all, we use a checklist, and there's a series of potential tools here that you can consider using. But there's also opportunities to understand that you can help them kind of work through breathing exercises. And before I get to there, these are some tools, but this is some sensitive questions that might be a little bit more vulnerable, speak to more of the vulnerability, may depend on folks who are transgender, gender diverse, folks who may have had military experience, they've been in active theater, not just on a base, but active theater. But it sometimes, even on the base, a lot of women have had, and males have had sexual abuse, in those, even without being in active theater. So you don't want to distinguish that one is worse than another. I don't want to make assumptions, but a lot of folks within the military may have had these traumatic experiences of one form or another. Family members might feel particularly vulnerable and sensitive to some questions. If they have a reaction, it might be something for you to, it may be indicative for you to explore that, because they're having a reaction maybe with a particular member. Maybe they're speaking about different family members while you're doing an assessment, but this one family member, they speak about them very minimally or just refer to them, but everyone else they talk about more extensively. That can be indicative. Suicide ideations. And also abuse and trauma, asking about those questions can certainly incur some issues. Asking directly about a person's experience of violence is essential, but it can be difficult for both you as a provider and the other person. You know, when it comes to suicide, when it comes to abuse and trauma, you don't want to dance around the subject. You want to use a particular tone of voice, and you want to ask the questions and very directly, but in a supportive way. So some people can, you know, discuss their experiences. Some have come to understand their views, not everyone. Some have become to consider that they may be having long-term effects of it. They notice that they don't do certain things anymore, and they're aware and they can connect it with some of the past experiences. Sometimes others are not able to identify the link to those situations. And they just hear questions and can create turmoil with the, sometimes hearing just the questions can create discord with the particular person. Sometimes labels, it's not a really good thing. Allow the person to express whatever their experience, or speak to the question in their own words and work with that. And so, because it can incur, you know, some reactions. And so, and when we're talking about meeting with somebody where they are, we want to understand, you know, how we go forward may have to change. Sometimes we want to preface, it might be a good idea to preface before you start asking some of these sensitive questions, letting you know these are the type of questions you're going to ask, and that if at any point they feel discomfort, or, you know, or they don't want to answer a question, that you will follow their lead. You know, it'll be up to them. And if they want to stop, that you can stop, they can have a few minutes, and then we can start again when they want, you know, or they can bypass a question and they can go on to the next. You can always come back and fill in the response to that question later. So that way you are actually showing them that you're supportive of how they feel at any given moment. And so that's important also for them to kind of get that sense from you that they can be safe with you, that you really have their best interest at heart. So the Center of Excellence for LGBTQ+ behavioral health equity, these folks have been putting out some very updated information about how to work around non-binary folks and different issues of substance use, how to do screening and brief interventions, how to engage, how to create affirming environments. OMH has just had several different dates that have been distributed amongst our field, and there have been webinars on how to create these environments. Trauma-informed care for folks in the LGBTQ+ community can look like this. This really speaks to how those guiding principles can be applied in the settings. And so whether it's to demonstrate an affirming stance, honor and celebrate sexual and gender diversity through language. I'm always talking about the importance of using recovery-oriented, empowering language, not stigmatic language. The visual representation, when I say culturally appropriate, representing the communities you serve. So that also includes persons who are non-binary, you know, and staff that's trained to be, you know, to be affirming just naturally with everyone. And so the peer support and the other principles you can see here, this will be in your materials. When you're doing an intake and assessment, one of the things you may want to recognize, if for some reason you start to see a difference, when they first came in, you're asking questions and you see a fixed or glazed eyes, they start to tear, they feel confused about some of the questions you're asking, maybe a sudden change in their mood. Maybe they came in somewhat energetic, very friendly, and then they start to, and their mood seems to darken. They kind of start to say less, you know. Maybe there's long periods of silence. Their voice tone kind of changes. These can be, and especially if this is what's happening when you're gathering information. These can be links and the red flags that can tell you what you may need to explore with a given person. So if someone's reacting, one of the things you want to do is, one of the things that you can do in care of someone, before I say anything, I'm going to ask you, what do you use, or have you noticed a client that might get a little anxious, might get a little irritable when you're asking questions or during a session with you? What have you used to help them regulate or get into the moment? What has been, I really would love for you to share your experiences, so for everyone else to learn from. Go ahead, Laura.
I would ask the client if they need to take a break from the process. You know, just walk around, get some air, you know, just step away for a time, and ask them, you know, when they would like to regroup to finish.
Excellent, excellent, thank you. Jenna, what do you do with your clients when you notice anxiety?
So, you know, a lot of the times if they do tend to start like shutting down, or we can kind of see that maybe their mood is kind of starting to escalate a little bit, you know, I'll either redirect the conversation into something else where they're not going to get so upset, or also a big thing is just validation. I think just validating the client a lot and explaining to them that although I don't exactly understand their specific situation, I can kind of just empathize with them, and that the feelings that they might be dealing with are normal. And that tends to kind of help them a lot, because I think a lot of the times when they do start to shut down, it's because, you know, they either don't want to be judged or they feel that these emotions aren't normal.
Mm-hmm. Okay, thank you. Excellent. Alisa.
So I work in a high school setting, and I know a lot of times like meeting with new people is difficult for them in the first place. So I try to facilitate like a welcoming environment when they first come in. I'm always like, you know, I have like a basket full of fidgets. I have boards that they can draw on. I have like a little Zen garden. Like I tell them like, you know, bring something over, bring the whole basket over, like try to make it as comfortable for them as possible. Cause I'm like, you know, I'm going to be getting to know you, like asking questions. Like it might be like some difficult subjects, I said. So like if you need to take a minute, you need to pause, like just let me know. Or if I notice that they start to get a little like shaky or teary, I'm like, hey, let's take a moment, like let's pause. I'm gonna let you get yourself together, and then, you know, we can regroup and get back to it. Like, does that sound okay? And usually like they nod their head, and I'm like, okay, like you let me know. Or like I always have snacks because they're high schoolers, they're always hungry. So I'm like, you know, take a minute, get a snack, and just kind of let them lead and tell me like, okay, I'm ready, I got this. I'm like, all right, cool, let's get back to it.
Wonderful, thank you, Alyssa. I appreciate everything that you've all been sharing. And there's some few in the chat box who agree with you in terms of the pause. Let them have their moment, and depending on the triggering factor, I would like to ask probing questions. Okay. And sometimes we can ask that after a minute or so, ask permission, but sometimes we need to come back to it at a later time. It really depends on where that person is, and let them lead. And so I see redirection also. My approach varies based on the history of rapport I have established with the person. The pause seems to be very important for everyone. And yes, observing, asking what they would like to talk about, that's huge. If the conversation starts to redirect, and it actually incites information that has to do with traumatic experience, and they're speaking about it, give them the time and space. There are times though when we're asking questions and we see some reactions, like some of the ones that I mentioned in the slide, or maybe you see the agitation, or maybe there's an animation, the behavioral part. So I just want to just make sure that we're understanding. If you think about, I'm not asking you to relive anything, but if you think about any time where you may have just had, oh, that car got too close, and you just had a reaction, right? Or you saw a scary movie, or the first time you saw one of the scary movies, especially, I mean, back in the day, I used to love it. The scarier, the better. I loved it. I'm a little wussier now. I don't see those movies as often anymore. I've become a little bit too sensitive, I think. But I used to love that initial reaction, you know, and like, oh, it scared me. So that was part of how I measured how good a movie was. And so sometimes somebody will watch a movie, sometimes have a kind of what we call a close call. If you are in any kind of urban area where the light changed, the cars are still going, and you were about to like go forward, that could be a moment where your heart rate kind of went up. Anxiety and questions, you know, it can look so many different ways. It can be triggered by so many different things, but feel the same way. So there could be questions that you're asking an individual, and their heart rate starts to go fast, and they get a little agitated. They may not necessarily be aware, or maybe they are, but they're not saying anything. You can be aware that their body system, that they seem to be responding a little differently. They're getting agitated, they're breathing faster. Your body, remember the sympathetic system, when someone is activated, that part, the person's body system is not regulated. Everything is on a heightened state. So the breathing goes faster, the heart rate goes faster, the pulse rate is faster. And so your body feels it. So something you could do is really simple. You can ask the person, does he seem a little agitated right now? Would you mind if we do a little exercise right now? Maybe kind of breathe and just so we can kind of come down a little bit. Would that be okay? If they say yes, something as simple as breathing in 4 times for 4 seconds. Hold it in for 3 to 4 seconds, depending on the individual. Everyone has different respiratory capacities. And then breathe it out and breathe it out. I used to get my clients to do it like slowly. I used to say as like a whisper. Do that 2 to 3 times. Even any one of us, when we're running, we're doing walking in place, when we're doing exercise, our bodies, start to get, we start to go fast. We expedite everything. Everything goes faster. Our heart rate, our breathing, everything. It's very similar to what anxiety does to the body. So what we could do is just breathe in through our nose, out through our mouth. 4 counts, 4 counts, 4 counts. What you'll know, do it yourself. What you'll notice is that by the second time, you'll notice that your heart rate starts to slow down. When your heart rate slows down, when your pulse rate slows down, you're not caught up here. You're not caught up in your body. This here on top, your mind starts to relax a little bit. So when we can show our clients to do that, it can be so helpful because it gives them a skill that they can do for themselves when they're not around you. First, and it helps build a rapport with you also. So I used to facilitate a group. It was a prevention group, one of my past career moves. And the last 5 minutes of the group, I used to suggest, I would say, is everybody ready? The fluorescent lights would be on. And it was always during the daytime, but I would symbolically turn off the light. This is where we spend the last 5 minutes. We've talked about so many different things, personal issues come up. And I said, how about we kind of just make sure we come down to a calm space before we leave each other. And I'd have them close their eyes and I'd have them breathe in for 4 seconds, 3 to 4 seconds to hold it, and then 3 to 4 seconds to let the breath out as slowly as possible. Between the second and third breath, everything in the body is calmed down. That way, that person is more likely to be able to articulate whatever's going on with them. So that is something you can consider doing. The breathing techniques are hugely important. If it's something that we get triggered with a particular person, if they're telling their story and we get triggered and we see our physical reactions, we can use the same process for ourselves. It'll give us a few seconds, a few minutes to regroup and then be present for the person. So the physical reaction tends to be a major part of how clinicians work with on helping patients understand how to deregulate, how to regulate their body systems. And then it brings them down in a calm space where they can talk things out and feel safer. And so if they're ready to speak at that point, you speak with them. If not, you can wait till later, give them time and space. So these are things that you could do in the moment. It's very similar to the de-escalation skills that we use when we have volatile situations in our work setting, but this is with the individuals, very simple. Practice it for yourself so you can practice it with them. So the box theory is one of the grounding exercises that uses the breathing. Over here is the person offers the break, and it's a 5, 4, 3, 2, 1 grounding experience. You take a few deep breaths and then you ask the person, acknowledge what are 5 things you see around you. And this is especially important for folks who are having a reaction to a memory. They don't necessarily have to have exactly a flashback where they're actually there and not present, but this is one way to make sure they come back mindfulness and come back into the moment. So after they've done the deep breathing and they've more regulated their body system, ask them 5 things that they see around them to identify those 5 things. Ask 4 things that they can touch around them, 3 things that they think they hear, 2 things that they think they smell, 1 thing they think they can taste. But the idea is it provides the opportunity to help that you can help that person come back into the present moment. And so it starts to break off those reactions to linked memories and they're back in the present. So this is just one of many techniques. So concluding a session, what I would suggest is like when you have an individual, know what the next steps will be for them. If they share with you traumatic situations, well, tell them, I'll call you tomorrow to check in. Let them know you're still there for them, even though you're not going to see them. What if you're not scheduled to see them for a couple of weeks? And you could say things like, well, I know you're going to be coming around here because you mentioned that you had this other appointment with so-and-so. So I'll be here between this time. If you want to drop by my office and let me know how you're doing, or if you want to speak on anything, I'm here. It's the opportunity that you have to let them know that you're a resource, you're a support for them. So the idea of being hopeful is hugely important. One of the best ways to get through situations that are really impactful is that alliance with other people. So sharing that hope is important too. I appreciate your participation here today. Thank you for taking the time and energy to go through this with me. I look forward to seeing you again. So trauma-informed supporters provide the time and space, help the person identify sources of support, understand what their sociocultural perspectives are, the reality of their world, help identify resources that are realistically accessible to the person, but are also going to, that speak very much to the person's needs and the ways that they can, that particular resource can engage your client. So encourage them to get plenty of rest, and there are times where folks are not trying to isolate. There are times, folks, that people really do use space to process their information. That's not a bad thing. That's just a healthy coping skill. We don't have to assume that just because people do like to take their alone time, doesn't mean they're isolated. Many times it's what they need to do. As we get to know them, we might start to understand that that's part of how they process information, how they make informed choices for themselves, how they can build their own self-awareness. So discourage the person from using negative coping strategies, certainly about not going to people, places, and things that might, incur a relapse, or working too hard, and other maybe self-destructive behavior. So strength-based, culturally informed approaches to promote resilience is helpful. And the last thing I wanted to say, and we started to speak on it already, is the well-being of you folks as providers on your clients and your patients. Get peer support for yourselves. It's hard to do this kind of work and not feel it, and not be impacted by the different stories you hear, by the different environments folks come from, by the stresses and challenges, not just from the job, but trying to be supportive to you and helpful to any given client you're working with. And then you have to live your life too. And so you have your own challenges and stuff. So we were talking about balancing things out well, and really engaging in other things in our lives, really important. So seek out peer support. Colleagues who understand where you're coming from. If you don't have clinical supervision, that's okay. Get a resource where you can have that option, where you can go to someone that you can get that type of support from. Train yourself on it. Train different things. We've already come to the trauma-informed care, but there's other things you can do too, such as understanding what kind of opportunities you have that speak to who you are, that you find important, that helps you feel that you are doing something that you like and enjoy, and it's not necessarily work related. So it's kind of like therapy for yourself. Who likes to cook? So a lot of people like to cook. A lot of people like to paint, So those spiritual activities, it could be a faith-based community that you're involved with. It could be other spiritual things. Spirituality is really defined by the individual, the different things that speak to who you are, not just your work. So you want to be involved and continue to nurture yourself as a person. And the more you do that, the more you build your own self-awareness, where your awareness to a point where you can probably see it, have a higher likelihood to see it in other people as well, because you have your own experience that you can relate to. Doesn't mean you have to share your experience. It just means that if you can see how it can happen to you and it's very individualized, you can see that it possibly can happen for different people. Trauma is so prevalent with the communities we're serving today that if we don't bring our healthiest people forward, we don't bring our healthiest selves forward, a lot of folks are going to go without the help they need. And it really does begin and end with us. We have to get our own support and help in place. Any comments, any questions? Okay. What is one thing that you're thinking that you could do for yourself this weekend?
Well, myself, I'm really into Halloween, and this weekend I was like, man, it's going to be a busy weekend. I don't want to do anything, but the new Halloween comes out, and so I shouldn't say forced, but I made myself buy tickets for my family and made a time to go rather than, oh, we'll do it next week or we'll wait. So we're doing it this weekend.
Thank you for saying that. You know, a lot of times that's what we do. We say, okay, not this weekend. We'll push it off. We push ourselves off. We don't push our clients off, but we push ourselves off. Hey, how about that? Thank you, Amanda. Have a great time. We are also looking forward to the holiday, and the community here really takes an extra step into it. Even the parents come with the kids all dressed up. It's kind of nice, you know. But there's a lot of folks who put here, you know, going to this. Oh, that's awesome! You're going to the state fair. Exercise releases what? What does exercise release?
Endorphins, and endorphins make you happy.
There you go. Makes us happy. Kind of calms us down. That is so cool. Family dinners. You know, a lot of the different things that sometimes we forget, or we're too tired, or we're just going to rest this weekend because we're too tired. That's really crashing. So there's a difference between crashing and actually resting, you know, and so make that distinction for yourself and just participate in your own life. And that way, when you come back into your work life, you're in a better position to help others because you already started to help yourself. So you keep grounded because we need you. So, and with that, I thank you for your time.
Thank you, Diana. Have a good weekend.
Thank you.